it's a minimally invasive approach to the salivary glands, primarily two, and specifically the parotid and the submandibular gland, the two that cause the most problems for benign or non-cancer problems. So salivary stones, sometimes just the secretions get thickened and cause blockage of the sinus or of the salivary gland, and other problems such as even radiation for thyroid disease or other kinds of radiation for head and neck cancer can cause blockage, as well as just repeated trauma or repeated infections can cause problems as well. It's a fairly common problem. It tends to occur more in the submandibular gland, or those are the glands that are kind of down here under our chin, and they kind of loop up, and if you look under your tongue, you kind of see those two little bumps to the side of the frenulum of the tongue, and right around there, not exactly there all the time, but right around there is where they drain, and that's where, sometimes people accidentally squirt some spit out when they're talking to people. That tends to be where it comes from. Those are the submandibular gland ducts, and there's a few reasons why the spit that comes out of the submandibular glands is a little thicker, more mucinous or more mucus, so it's a little thicker, so it can get blockage or move a little slower where it can get infected, or it also tends to be a little more alkaline where it can develop a stone. It's also gravity, so the plays a role because the gland's here and it's got to empty higher up, so it doesn't have gravity helping empty the duct or empty the salivary glands, so that also increases the likelihood of that spit just kind of sitting there, and when it sits there it can precipitate or turn into stone just like a kidney stone can, and then also because of its location it can get infected more easily, and that infection sometimes can contribute to development of that stone. Really not that big, so but it all depends on where it is. And even when it's small, it still causes pretty significant problems because of just the size of the duct. So generally speaking, these stones are probably anywhere from usually on average about 3 millimeters in size, so pretty small, so probably anywhere from about 2 to 4 on average. Sometimes they get as large as 5 millimeters, 7 millimeters, almost a centimeter in size, which is probably about the size of your thumbnail. And then the symptoms they get from them are a lot kind of like having a kidney stone. So every time you eat, and you want to, your brain tells you I need to make spit because I see that juicy steak, it hurts. Your spit gland swells and it's a pain. It's paroxysms, just like when you need to pee and you get that urge, and the kidney stone's blocking. In the same regard, this swells up, severe pain. The spit backs up in it because you're making more spit. And that occurs when people brush their teeth sometimes. Some people are just sitting there thinking about something that, we just, and then just throughout the day we produce spit, but particularly when people eat, they tend to make more, and that's when they notice those problems more. And then ultimately with that backup of that spit, it just sits there, it stagnates, it's nice, toasty, body temperature. And like I said, even especially with this lower gland, but even with the parotid gland as well, the bacteria can come from your mouth and then infect that spit, and then it turns an actual acute infection. So not just the stone, but infection occurs behind the stone, and oftentimes people have these small stones where they may not be able to feel the stone, but this happens over and over again. The infection gets treated with antibiotics, it goes away. A month later it comes back, a month and a half later it comes back, and it's over and over and over. Chronic problem, yeah. Sometimes they get the stone the first time we identify it, we're able to take it out before they get these recurrent events. But a lot of patients I end up seeing are patients have seen other doctors where they get the problem over and over and over again, or where it's known that they have a larger stone, but really the procedure to take it out is quite an involved procedure where they're just treated every time they get an infection versus just treating the actual problem, which is removing the stone. And before this advent of Sialendoscopy, it was a much more involved procedure through the mouth where you had to open up the duct and it's kind of plastic surgery in the duct essentially, or actually taking the actual whole gland out, which is a neck incision.
So more radical then.
Exactly, and requires usually a stay overnight typically, but exactly, there's risk to that. Of course the incision and risk to some of the nerves that control movement of the lower part of the face, that kind of thing. So it's nice to avoid those risks when we can and do a more minimally invasive approach and target right where the actual problem is, which is what the Sialendoscopy is all about. In the future, this will be the standard of care for taking care of benign salivary gland tissues. Just probably in 5-10 years, just like everything else, there's people that adopt these techniques early adopters, and that do them and provide them for people. And there's the bulk of physicians and other people that do it, accept it once it's become more mainstream, and then there's the group of people that are kind of the laggers that do it only after, with a reluctance sometimes. So that's classically how anything medical is performed, whether it be the robotic surgery we do here at Aurora Medical Center Summit, or if it's other minimally invasive surgeries like thyroid surgery as well. So when we do these procedures, typically the patient can advance their diet the same day. They don't need to be on any special diet afterwards. Rarely when we have a large stone that we have to open up and expose, I do put the patient on a softer diet for a few days afterwards, but usually not affecting their diet. They're able to resume normal activity, not take any work restrictions necessarily, have to take off of work. And when we do these procedures on patients where they don't have a large stone where we need to remove it or use a laser to break up the stone or things of that nature, I actually can do this procedure under monitored anesthesia care, or partial sedation, kind of like when you get a colonoscopy, or actually do it even under local for just doing examination. And people can walk out of the and do well and be back to regular activity if they're under local the same day. But even with the monitored care later in the day, or oftentimes the next day, there's not that kind of classic feeling lethargic and having some of the problems associated with the anesthesia. So that's one of the benefits, is that people can get back to regular activity if it's right away, versus a neck incision, or some of the more traditional approaches like a neck incision, or even the intraoral approaches for bigger stones where it was a more involved procedure. There's a percentage, and probably I'd say about a third of just all comers, all patients that have these kind of chronic recurrent salivary gland infections, particularly the submandibular gland. This applies to more, but also even with the parotid gland, and probably about a third of them are stone related. And then because of that, they get these recurrent infections, and sometimes because of the stone, or it's kind of the chicken and the egg, they can have narrowing because of the stone, so scarring in the actual duct where it's narrowed, or stenosis, where we have to dilate that up and put a stent in sometimes so that it doesn't close down again. And that's what caused the stone to collect, because there's that narrowing from some other trauma, or a previous infection, or sometimes because people have Sjogren's disease, which is an autoimmune disorder where essentially your immune system attacks your salivary glands and other parts of your body. But or even radioiodine therapy decreases salivary gland production and causes these problems. I just had a patient I just took care of a few weeks ago that had that exact problem, and recurrent bilateral spit gland, parotid gland, and we were able to treat that and cure that.